I'm Dr. Laurie Mooney. I'm the medical director over at the Sleep Lab, which is on the third floor in the main hospital. We have a clinic by day and run the sleep studies by night over there. I'm going to talk to you about insomnia this evening. I might as well tell you the bad news right now. I don't have a magical cure for insomnia. But I'm hoping tonight to give you some information that may help arm you to combat your insomnia a little bit better and hopefully sleep better. So the agenda for this evening is we're going to go through some definitions of insomnia. I'll speak a little bit about different types of insomnia. We'll talk about how much sleep we actually need, the causes and the risk factors for insomnia, how to diagnose it, what are the consequences of insomnia, and what to do about it. And I'm also going to try to see how many times I can say insomnia in the next hour. So the definition of insomnia can be any of these first four problems, and then it has to include the fifth problem. So it can be an inability to fall asleep in longer than generally 30 minutes is what's considered normal for an adult to fall asleep. It can be the inability to stay asleep with frequent awakenings or waking up and can't fall back asleep. The issue can be waking up too early or waking up just not rested or non-refreshed. And then it has to cause some perceived distress or daytime sleepiness or daytime impairment. So there's acute or short-term insomnia, which I guess most of us have all had, where it lasts just one night or a few nights and doesn't quite meet the criteria for what we call chronic insomnia, which now has to last for at least a month and it has to occur at least 3 times per week. Chronic insomnia, they say, affects about 30% of the population. Seems to me like it might be getting more common. I think ever since smartphones came out in about 2007, 2008, people are staying up later on their phones and whatnot. And then there's primary versus secondary insomnia, which primary basically means that we haven't been able to figure out a cause for the person's insomnia. And all the secondary insomnias, for example, if it's secondary to depression or acute pain or acute illness or something like that, then you could say it's, it's a secondary insomnia due to a known cause. How much sleep do we need? The answer is basically how much sleep you get that makes you feel refreshed the next day and functioning at a good level. The average need for adults is between 7 and 9 hours. This can vary a bit based on probably genetics and maybe some other factors. This is like a bell-shaped population curve that just shows that most people are sleeping in that range of 6, 7, 8 hours. There are outliers on both ends, for most things, where people who are getting 4 or 5 hours of sleep, there can be those that say they only need that much sleep and they function fine. Where it becomes more pathological, though, is if they're only getting that much sleep and they don't feel well the next day, and that's kind of where insomnia fits in. But there are some other causes, such as insufficient sleep syndrome, which is kind of a fancy term for somebody's not allowing themselves enough time in bed, like just not getting to bed in time and having to wake up early. Risk factors for insomnia are I like to think of, are kind of things that you can't really change, like age and gender and genetics. But definitely insomnia is more prevalent in the over 60 age, and women have it a bit more frequently than men. As far as family history, there's usually quite often a first-degree family member, such as a parent or a sibling, that also has insomnia. And then night shift workers and swing shift workers often have insomnia, just a kind of a function of their disturbed sleep or not being able to sleep so well during the daytime. So here's all the causes of insomnia. And as I was preparing this, I was thinking, good Lord, how do any of us actually sleep with all these things that can potentially go wrong? But poor sleep habits is way up there on the top. And the three biggest things are, I think a lot of times these days, scrolling on your phone or your tablet or your electronic devices late into the night. The second one is just irregular sleep habits, not keeping a regular bedtime and wake time. And then the third is falling asleep really any time during the day can mess up your nighttime sleep. We have, as far as something called circadian rhythms in our brain that regulates our sleep-wake schedules. And part of that is, as the day progresses, we have something called a sleep drive that increases, especially in the late afternoon, evening, and it's highest as you're about ready to go to bed. If you fall asleep anytime during the day, but especially worse toward the evening, it resets your internal drive to fall asleep to a later time. There are a whole lot of physical disturbances that can disrupt our sleep, such as lights and noises. Particularly in terms of lights and noises, a television, I think, is fairly bad because TV lights change a lot with the show you're watching, and also does the sound from television. The ads, for example, come on a lot louder than your normal show. So we usually try to get people to turn off their TV or have it on a timer or something, but having said that, I have lots of patients that cannot sleep without their TVs on, even to the point where they won't even come in for a sleep study if we don't promise them that they can watch the TV all night or leave the TV on all night. Stress is probably the number one thing that people tell me about their insomnia. They just can't shut off their brain or turn off their thoughts, and worrying about their adult children or their finances or everything there is to worry about these days. Major life changes often are a trigger for chronic insomnia, such as the loss of a loved one or a job change or retirement or something like that. Those kind of things can often trigger, many nights or weeks or months, sometimes even, of insomnia. Other sleep disorders can cause insomnia, especially sleep apnea, restless legs. There are several others as well. And then travel across time zones and daylight savings time often sets off insomnia for a couple weeks. Since I mentioned sleep apnea, I wouldn't be true to myself if I didn't talk a little bit about it, because that's sort of the bread and butter of what we do at the sleep lab. But sleep lab can cause insomnia basically without the person knowing it. So I'm going to talk about it for a couple slides here. The definition of sleep apnea is that people have repeated episodes of stopping breathing for more than 10 seconds, and it has to occur more than 5 times an hour to be considered positive. It's disrupting to sleep because it causes, at the end of an apnea, which is a period of no breathing, then there's an arousal. Arousals and awakenings. And arousal is where we see the brain waves go to a brief awakened state for more than 3 seconds. So is a sleep study needed to diagnose insomnia? I did put this slide in there right after the sleep apnea part because the answer is maybe. For pure insomnia, you don't need to have a sleep study, but if we are suspecting that there may be another sleep disorder as a cause, or sleep apnea particularly, then we usually do go ahead and do a sleep study. This is our sleep lab. That's just kind of the hallway there, and that's one of the patient rooms. We have 4 bedrooms. 3 of them have these nice queen-size sleep number beds, and then one's like a hospital-type bed for mobility patients. And here's another type of sleep test that you can do at home, a home sleep test. This is the type that we have with the apparatus that you come in and pick up at the sleep lab. We show you how to put it on. You take it home and wear it for one night, bring it back the next day, and a lot of people like that better than coming in the sleep lab. But that's mostly just for diagnosing sleep apnea. It doesn't, when you come in the sleep lab, you have all these leads on your scalp that are measuring brain waves, so we can tell a lot more about your sleep if you come in the sleep lab. But if it's just an issue of whether we want to know if you have sleep apnea, then oftentimes the home sleep test is adequate too. I wanted to say a word about smartwatches because just last week, and I'm talking about your Apple Watches or your Fitbits or whatnot that people wear to sleep, but just last week I had 2 people come in showing me on their phone their data from their smartwatches, and they were both very disturbed because they were waking up 10 times during the night. And I said, well, are you aware that you're waking up 10 times during the night? And they said no, but it's causing them some anxiety, I think, or making them upset about their sleep quality not being good enough because of these results that they're seeing. And I'm just afraid that people are going to just get upset about the results when they don't really need to, I guess is what I'm trying to say. So what the watches have access to is basically just your heart rate and your movements. So by all these different algorithms that are programmed into it, it tries to tell you how many awakenings you've had, how many position changes. It tries to estimate even what stages of sleep you're in, but I just don't think it does a great job on those. But I would definitely go, base your own symptoms based on how you feel you're sleeping and how you feel during the day and whatnot, and maybe not worry so much about a bad number on a watch. So the effects of insomnia are many. A lot of these are like the topics like delayed reflexes and reaction time and things like that are actually from studies of sleep deprivation of any cause, but since that is what insomnia causes, that's where they get some of this information. But basically feeling tired or unwell or sleepy. I had a patient today just tell me, I just don't feel well. And she couldn't really describe it better than that, but I mean, we kind of know what that means. So delayed reflexes, memory problems, irritability, disruption in work or social routines, and slowed thinking or trouble concentrating. Those can all be a result of insomnia for sure. So I'm going to get into the treatments now. There's basically 2 big arms of treatment. There's behavioral and then there's medication. There's 3 types of behavioral therapy. One is just called sleep hygiene. I'm going to go over with you in a lot of detail because I think that's the most important thing. There's something called cognitive behavioral therapy and sleep restriction therapy. So good sleep hygiene. This is kind of a busy slide, but really important. So I'm going to go over everything pretty carefully. Regular bedtime and wake time is really important. So if people are really having trouble, we'll tell them to set an alarm in the morning. Make sure you're getting up at the same time every morning. I've been more recently even telling people to set an alarm at bedtime. White noise is a really good thing in my opinion. There have been studies that have showed white noise was equivalent to a sleeping pill. What it does is basically just drowns out any noises in your house or outside of your house or anything that may be waking you up during the night. So I'm a big fan of fans and white noise. You can do a fan, you can do, there are little white noise machines that play all different kind of sounds, and there are apps on your phone that can do white noise. Bedtime rituals are very helpful for just kind of calming you down at night, like a bath or a shower. like I mentioned, your body is trying to cool down at night, but it is okay to take a hot bath or a hot shower because they think that when you're drying off and your skin is still wet, that cools down your body temperature. A notepad is one of my favorite things, and this can be either an actual pad of paper by your bedside or a to-do list on your phone. I have that on my phone, but what the idea with that is if you are about to fall asleep or you wake up in the middle of the night and you think of something that you have to do tomorrow or you have to pick up at the store or just something that is nagging your brain, just get it off your brain and write it down or put it on your phone. If you pick up your phone for 10 seconds in the night, it's not going to mess up your whole light and dark thing. So just getting what's on your mind off your mind and letting yourself get back to sleep. So get up if not sleeping. That applies to both at bedtime and if you wake up during the night too. The idea is that they don't want you laying there in bed for long periods of time because you can actually develop increased anxiety and arousal if you're laying there for a long time just ruminating about I'm not sleeping, and that can actually develop into its own insomnia. It's like sort of like insomnia begets insomnia. So there's a term for that type of insomnia. It's called psychophysiologic insomnia, where you have a night or two a bad night, and then it perpetuates itself. And you can actually get to the point where you're just dreading going to bed. And so this is supposed to prevent that. If you get up out of bed after the 30 minutes and go, you're supposed to go to another room that's kind of quiet and comfortable and do something not too stimulating until you feel sleepy again. And then just try again. Clock watching. This is probably my favorite slide. I don't have a problem with clock watching, but I am here to tell you that this works. If you change the way that you think about looking at the clock, I promise you this works. Instead of saying, oh no, I only have an hour left to sleep, you tell yourself, yay, I have an hour left to sleep, and I do this, and ever since I learned this. So cognitive behavioral therapy is something that kind of technically used to be guided by a therapist. There are different kinds of cognitive behavioral therapy. There's one for anxiety and depression, and so the one with the I on the end is for insomnia. The progressive muscle relaxation I really like because it's very simple, and you can do this in the middle of the night, and it's kind of a fancy term for basically you start at your toes and you tighten your muscles of your toes and then you relax them, and then you go up to your next muscle group like your ankles or your feet, and you tighten them and you relax them. And the whole idea is kind of just so you're going to fall asleep sometime before you get up to your head, most likely. It's kind of, again, distracting you from your negative thoughts in the middle of the night. This graph is something we call a hypnogram, where it's got your sleep stages on there. This line, the W is wake, and then these are different stages of sleep. There's stage 1, 2, 3, and then REM, which is the red one is the dream stage. So this is a person who spent 9 hours in bed. It's from 10 p.m. to 7 a.m. And this is what the brain will do if you spend too much time in bed. It spreads it out over the whole time that you're in bed. It'll spread out your sleep, and it just basically guarantees you insomnia. It's not something that you would, I think, normally intuitively know, but and so this person, it took them about an hour to really get to sleep. They were having some little light stages of sleep here before they got into some deeper stages. But what I wanted to point out is each of these little blips up to the wake is an awakening. And I counted them, and there's over 25 of them in a 9-hour stretch there. So when this person woke up, you better believe they didn't feel like they slept worth a darn. There is a thought or an idea of this sleep restriction therapy. And basically, you're condensing your hours in bed to approximate how much time you're actually sleeping. Every fall I go to the OSU Sleep Symposium, which is for sleep providers, and for the last many years they've been talking about lowering the dose of melatonin, the sleep experts that talk, down to like 1 milligram, 1.5 milligrams is really all you need. They do now have a combined regular melatonin and extended release melatonin if you suffer from both trouble getting to sleep and staying asleep. I've not seen it in stores, but I've bought some online, and I do a 1 milligram gummy. I think the gummies, I like them because you can start absorbing them right away as you're chewing them in your mouth, and so they're going to work fast. And magnesium is kind of a newer treatment that's touted for insomnia and restless legs, and also kind of lower dose is better, like 250 milligrams, 350 milligrams probably at the most. Chamomile is the tea. Ashwagandha is thought to be good for relaxing people and for anxiety, and CBD and THC are ingredients from the marijuana plant. Okay, so by prescription, I think this is my last slide. I will start out by saying that ideally prescription sleep aids are meant to be short-term for a few nights or a few weeks. If I have a patient who has suffered insomnia for a lot of years, sometimes we'll start with one of these with taking them every night for maybe 3 or 4 weeks so that they can just sort of retrain their brain to sleeping, with the idea that you'll start, after that point, once you're sleeping better again, you'll start tapering off and just maybe using it as needed. Do I have people in my practice who've been on Ambien for years and years? Yes, I do. The first category is medications that are for sleep only. That's all we use them for, which I like those because they don't usually have too many side effects or interact with other medications. And then there's a whole lot of antidepressants that, as a side effect, cause drowsiness. So we use those for sleep, like you've probably heard of trazodone or amitriptyline, doxepin, Seroquel, and Remeron. Those are the most common ones that we use for sleep. Those would be a good choice if you have both insomnia and depression. So that's kind of how I decide how to pick any of these. If I have somebody who's got insomnia and anxiety, maybe I'll pick something from this category. So the anxiety category, they're kind of in the brand of Valium, Xanax. Those are all in the same type of medications. So I just have our phone number up here. If anybody wants an appointment, we don't require a referral, but we tell people to check with their insurance first, and if the insurance wants you to have a referral from your primary care doctor, then we can make that happen. So, all right, thank you all. Thank you. Yeah, thank you.